Welcome back to Core Ultrasound number 14. Jacob Avila, Taryn Trott. We are the ultrasound division of the University of Kentucky.
That's right. And we're wearing the same clothes as last week. We tried to do that. We try to make it consistent.
Yeah, we don't want anyone to
get confused. Yeah. So 13 was good.
13 was really good. I feel like I learned a lot.
But I'm excited to learn more on episode 14.
Let's do it.
All right. Oh,
it's a heart.
Ooh, this is not a good heart. What if you're doing a pulse check on this obviously coding patient and you're like, somebody says they feel a pulse. What would you say?
I would be very surprised by that.
I would yell liar. Liar! So there's no way this is
Get out of here with that pulse check.
Get out. Get out. Spend 5 minutes outside. You're grounded. This is
cardiac standstill.
This is cardiac standstill. I mean, this is an ejection fraction of like 0.2%.
Right.
You know?
Right. There's no... Now, I remember there was a cool article that was published like a couple years ago, and it was all the different ways emergency medicine interprets some of these cardiac standstills. Because we see a little bit of flutter on the mitral valve.
Yeah.
That doesn't really mean anything.
It doesn't. It doesn't. I mean, this is like the same as PA. I mean, you can't shock this. This is such a low. I mean, you could maybe say that it's 0.2%. Ejection fraction. It's maybe something is moving forward, but not enough to generate, not enough to get past the coronaries. You know.
And we were talking just recently.
Oh my gosh, this is a big topic.
We were getting all fired up. We have to dedicate some time to it.
We will.
Does this mean we stop the code or no?
That's tough, man. I mean, I'll say that if this is, a 75-year-old with cancer and smoking history and diabetes and HIV and tuberculosis and, all of Chagas disease, has a really poor quality of life at baseline. The chance
arrest.
What's that?
Unwitnessed arrest.
2-hour
downtime.
Exactly. And then, 30, 40 minutes of CPR. If I see this, I'm probably going to call the code.
Yeah.
But if I see this and it's a 20-year-old that collapsed and got immediate bystander CPR, I'm not calling the code off of this, especially if it's been 20 minutes at that point, I'm probably not going to call the code because there's still a chance, and there's a chance because, there's a difference between ROSC and there's a difference between discharge with neurologic survival from the hospital.
Very important.
Very
important distinction.
So I don't think I wouldn't look at the ultrasound ever by itself and see this is the only thing I can use to prognosticate the patient. What are your thoughts?
I see this as asystole. This, maybe that mitral leaflet fluttering is going to give me a little bit of electrical activity. Yeah. I'm not convinced that it will, but this likely is just going to be a flat line. And I would treat it as any other time I see asystole. It's not looking good.
No.
But I don't use asystole to stop a code if it's...
Right. If it's not the right time.
Right. If it's not the right time.
I agree. I wonder, you see this movement right here? This one thing I always kind of like. See, there's a little bit of heart movement, right? Wait for it. There.
Yeah.
That's from venting the patient. That's from bagging them.
That's really important.
Yeah. To know the difference between that movement and not movement, basically. Whoa. This is another not good looking heart.
Yeah, this looks bad.
So this right here, it's not hypoechoic, so Correct. It's a clot, so we push thrombolytics.
Obviously.
All right.
Give him that $15,000 drug.
Yeah, done. Next. It's definitely going to help this patient.
Yeah, so we see this pretty often in codes. We're seeing spontaneous echo contrast.
Yep.
We're seeing stagnation of the blood. A little bit of movement. Doesn't really mean there's activity.
Right.
What does this mean for our patient?
Yeah, so if I look at this during a pulse check, I am not waiting for someone to tell me that there's a pulse. I'm not waiting for anything. I am saying resume compressions.
In fact, you might be reducing time off the chest.
That's true.
All because those anti-ultrasound and code people, you could quicken your time back on the chest.
Yeah, I agree. And this is one thing that Taryn and I are actually planning on talking about this.
Yeah.
But you got to be careful when you use ultrasound during pulse checks. I always use it pretty heavily at the beginning of an arrest because the patient might have massively enlarged RV. You might actually see a clot in transit. They might have a pericardial effusion. They might have a tension pneumothorax.
You're looking for those reversible causes.
Right. And in between pulse checks, things can change, and you can actually get information with the ultrasound. However, you still have to run your code the right way. You can't start using your ultrasound as a reason to prolong that pause. 10 seconds is always 10 seconds. It doesn't matter what part of the world you live in, where you're practicing medicine, 10 seconds means 10 seconds. So when your 10 seconds is up, it doesn't matter. Like if you forgot to get the right view, you need a little more time to get the view, your time is up.
Get back on the chest.
Chest compressions.
Now, I love this. I love finding something like this.
Me too.
It looks like a nebula or something along those lines. But obviously, we're looking at some anechoic something. We're seeing a little bit of
Strandy boys. Right there. And then this guy right here looks a little bit like the liver, but I'll tell you it's not.
It's not the liver, though, is it?
It's not. You could even say it's a liver-like lung or hepatization of the lungs. This is an empyema. This is like what a complex pleural effusion looks like.
Loculated empyema. Yeah. So now my question on this, because we see this a bunch, how often is this not infected? Because my default is to think that this is bacterial infection.
Right.
I don't know. Are there other things that cause this?
I don't think so. Although I imagine that a chronic or inflammatory process could cause this. So, I mean, you can get for instance, like a pericarditis effusion around the heart can actually have little strandy things like this.
Yeah,
and it doesn't mean it's infected. It just means it's an inflammatory process. So I imagine probably, but if I see this, I'm assuming that it's pneumonia.
I'll do a deep dive.
We'll do a deep dive.
We'll do a deep dive.
So how often are you identifying diverticulitis on ultrasound?
I'll be honest, Jacob, not very often.
I know, but look at it. Look at that little diverticulum. I mean, what else? I mean, so to be fair, I don't hardly either. I really don't.
Things in context.
Yeah, I don't either. But I mean, look at this. This is a diverticulum.
That's really cool.
Yeah, and we also have, you see, that's a little increased echogenicity around it. This is fat stranding. So we're seeing the same signs on CT scan, but we're seeing them with
increased density on the CT scan. This is what we see on ultrasound.
Yeah.
Now, is this a little bit edematous, the wall here? We're seeing a little bit anechoic. Maybe you could measure it if you wanted to. Maybe you don't have to.
Yeah. The reason why I don't do this a whole lot is because of two reasons. The first one is because it hurts. You have to actually push down. I mean, that's literally the thing that's causing pain. Right?
Yeah.
So that's number one. Number two, a lot of our patients have a little bit of increased adiposity.
Okay, sure.
And so it can be kind of difficult to get the appropriate resolution. If you look at this, I mean, the distance between the skin and the peritoneal lining, which is probably this here.
Yeah, that looks right.
Is 1, 2,
that looks like
3,
muscle.
4. It's 5 centimeters deep, which it's fairly deep to get a high resolution image, you know? So it's not something I do all the time, but it is for sure an option, and it's evidence-based as far as its specificity, like way evidence-based.
If you see something like this, you can be pretty confident. Okay, cool.
Yeah. I think it's a cool case. Oh, this looks like something up your alley, buddy. Yeah, yes. Some advanced echo stuff. What are we seeing here?
So we're seeing the apical 5-chamber view. We're mostly focused on the LV.
Okay.
I see we're doing some pulse wave Doppler. I love it.
So you're looking for the flow through the LVOT into the aortic valve.
That's right. I'm using this all the time to get an idea of the patient's stroke volume, response to some kind of intervention. But I thought this was a good one because it shows us one of our pitfalls of looking at the VTI.
Oh, teach me more.
So this waveform, this negative deflection is the flow going down away from that gate. It's not very pretty.
It looks really raggedy.
Yeah, there's a lot of different velocities being measured through here. So we love a VTI that's got that nice, beautiful, crisp outline. This is not that VTI.
Okay.
So usually the problem is you don't have a good axis and alignment with the center of your blood flow going out.
I get that.
But it could also mean that there's just super turbulent flow going out the aortic outflow tract, aortic stenosis, aortic regurgitation, maybe even intraventricular gradient. So you might want to try and optimize your gait here. You can make a smaller gait, measure less blood flow velocities, or you might want to try and move it into more specific out the outflow tract.
Can't you change the angle, like, and have that little like green bar come this way or whatever?
Yeah, absolutely. Try and correct the angle. This, unfortunately, I'm not sure how to use clinically.
Yeah,
it's just too dirty.
So it should be like a nice little like kind of arc,
That's
like
right.
full, and you want it to be like not full. You want to have like it's a little bit of like kind of more bright on the outside and a little bit hollow on the inside.
Hollow
means that
on
you
the
got
inside.
a good one.
Yeah, all of your blood flow is going together in one measured velocity. Yeah,
perfect. Sick. Chest tube.
Chest tube,
Let's
right?
put a chest tube
well,
in there.
One, we're seeing lung.
Okay.
Of course. Now, this time we are seeing in short axis across the ribs. We're seeing the rib spaces. And now
lung sliding here.
Yeah, I see lung sliding.
But I don't see. I mean, I don't know what is going on.
I don't know. Just throw a chest tube in there.
I mean, it's a lung point, obviously.
Obviously, it's lung point. Why do I feel like that's not a lung point?
Because it ain't. There's a couple of things with this. The first one is that the probe marker is upside down. That's the other thing. The probe marker is facing down. That's the one thing.
All
Just
right.
by convention, the probe marker should be facing up, and it's
We're gonna
down.
find you, resident.
We're gonna find you. We're gonna give you appropriate feedback.
Inappropriate feedback.
In a respectful and helpful manner.
In a way to grow.
And in a way to grow. So this is actually probably the liver coming into view. So this is basically the end of the lungs, and now we're seeing an abdominal organ.
I was kind of between liver and heart. Heart was on my differential as well.
It could be the heart. To be honest, it could be the heart. It's just typically when I see the heart, it's usually a little more beady, you know? And I'm not seeing it. That looks more just like movement.
Respiration.
It looks like respiration.
It looks more like
movement,
respirations.
So it could be the heart, to be honest.
And we don't put chest tubes in livers?
No, not on purpose.
Not on purpose.
Not on purpose. So this is a heart that is definitely abnormal, but requires a little bit of, I guess, correction, maybe a little bit of feedback on it.
Yeah.
Now, looking at this, I would say that the first thing I'd say was, this is a patient with heart failure. The left heart, which is normally on this side, is bigger than the right heart, which is normally on this side, right?
Yeah. And then you start to pick up, and this is like one of the challenges when you're first learning cardiac echo. So what side is everything supposed to be on?
Right.
We've been there.
Oh, yeah.
It takes some memorizing, and it takes a little bit of dedication to the convention.
Yeah.
Ultimately, you're going to figure it out. You're going to interpret the images. The first thing, so we normally think of the left heart on the right side, just to mess with it.
Because the probe marker should go to the left
That's
side.
right.
Yeah. Which would be this right here. So probe marker is here. That's going to the left. This should be the left side.
That's right. That's right. We're seeing bubbles in. That was the first thing that clued me in that maybe we're backwards.
Totally right.
We're seeing these bubbles. I'm thinking someone's flushing a saline flush, or they're getting a fluid bolus. So it's showing up on the right side of the heart, and in effect, we're actually getting a little bubble study, and we're not seeing any bubbles on this side.
Right.
But you're right. That RV is still big.
Yeah.
I mean, the right atrium looks big.
Yeah,
the RV looks big. It looks super muscular, though.
Yeah. So probably a chronic process, maybe like a COPD heart. Just to be clear, this is actually the right heart, and this is the left heart.
Correct.
For sure.
Yeah.
Taryn mentioned that. The other thing, too, that's helpful is this little guy right here. This is the aorta. And the aorta, just like, I know there's going to be someone's like, well, actually, sometimes it's just like, the aorta is on the left side, okay? There's going to be like one out of a gazillion where it's like going to be on the right side, I guess. But if you see this, that's got to be the left side. Additionally,
solid.
Yeah, additionally, the tricuspid valve is usually a little closer to the apex relative to the mitral valve. So, yeah, a lot of clues here.
While we've been talking, I'm trying to identify the moderator band, which is, of course, only in the right ventricle. I don't see it. It's not helping us out.
You might, maybe a little right there.
Right,
You think that's like part of it's just out of plane or whatever?
I think I want it to be. I can't really convince me. Yeah, there it goes, right
That's
there for that
probably
one
it
clip.
right there. Yeah.
I think you're right. I think we're seeing biventricular enlargement, biatrial enlargement. This is probably chronic hypertension or COPD or something. RV failure from LV failure, from RV failure from LV failure, something like that.
Exactly right. Additionally, although I will say that, let's say that whoever got this let's just assume that they knew exactly what they were doing. They're like, I want it flipped. Okay, guys.
Yeah.
I want it flipped. So this would actually be good because you can actually see the whole outside of the ventricle there.
Yeah, you don't see the RV in a not that this is a perfect apical 4. You don't get to see good resolution sometimes.
Yeah, so if that's the case, like we can see that whole thing so well. So not a perfect. In fact, this is called an RV modified view, I believe, where you tilt the transducer a little bit like down this way to get more of the RV. Yeah, in the view. Oh my! You know this right here. The first time I saw this down here, that thing, I thought it was a leak. I thought that meant it was like a leak, but it turns out that that's just like a compressed IVC out there. This is a massive AAA.
Man, it looks rough. Like, why are there so many layers to it?
There's so many. It's like a really bad onion. You know, like a really unfortunate onion. We got like, this is the outer wall. Oh, it's another thing. Measure outer wall to outer wall.
Outer wall. Yeah.
But why do we have like what do we do with this information here?
So I'm assuming there's a component of acute on chronic.
Okay.
Because I'm assuming that we're having different layers here. We're having the anechoic is going to be unclotted blood. So I'm leaning towards this is the acute portion, and this is clotted blood in between layers of portion of the aneurysm.
Yeah.
Like here and then here.
Looks
scary.
It looks scary. I mean, what do you think? That's maybe 8 centimeters, maybe?
Yeah.
I'm just trying to like guide it from this. And also, if we look here at the vertebral body, the average vertebral body width in like an elderly male is about 5 or so centimeters. So you can kind of use that. It looks like maybe 1.5 the width of that. So that's what I'm kind of just guessing.
Now, should I do a bimanual palpation of this one?
Yeah. You need your physical exam to confirm it. Actually, kind of along those notes, I've actually wondered about that, about the ultrasound transducer, like potentially like causing rupture. It's never been reported, and it's never been reported.
No one's gonna report that one. Hey, that one time.
But it's also to the physical exam, you have to palpate it. So you literally are trying to push as hard as you can, like feel it. There's been no reported cases of rupture due to palpation. So I mean, I think your ultrasound's like super safe. Yeah. And we get that sometimes. We get that like patients will come in and say, I can see my aorta because they're a little skinnier and they can see it moving. Yeah. And, ultrasound would be super helpful.
And then you're immediately able to provide some reassurance to that patient.
Agreed. Another with
a high level of confidence.
Yeah, you know, I've actually found that the more I use ultrasound in like low risk patients, the more I turn to the ultrasound as almost like therapeutic instead of diagnostic in a sense. That's right. You know, to alleviate patients' fears.
Yeah, when you show the patient what you're seeing and they can, absolutely. Yeah. Is that it?
Yeah, that's it. I mean, that's it for now. We got like.
I was having such a good time.
We have like 200 images to go through because we haven't. You know what I mean? Like
we'll be back.
Yeah, we review 500 to 800, I think, scans a month. And so we're just picking out like the really good ones. But we'll have more coming. And until next time.
That was fun.
Yeah.
Until next time.
All right.
We'll change our clothes.
Maybe.